covering on all practical aspects of CAKUT. And today we have two eminent speakers and excellent moderator, Dr. Rosanna. And I request Dr. Amrish to introduce a moderator.
Yeah, thank you so much, Dr. Kalavani. Welcome you all to the 4th annual Webmaster series. This is the 5th webinar for this series. It has been a great success. We have had great speakers in the last few weeks, and we are really excited to present this lecture today. And to moderate this, the two lectures today, I have my colleague and my friend, Dr. Rosanna Baracco. She did her MD medicine from Peru, and then she completed her pediatric nephrology fellowship from Children's Hospital of Michigan, USA. She serves as the director of the Pediatric Nephrology Fellowship Program here at Children's Hospital of Michigan, and she is also an associate professor of pediatrics at Central Michigan University. She is very interested in taking care of pediatric dialysis patients. She also runs our vasculitis clinic, and her clinical interest is also children with hypertension. She has won numerous awards. She has won the Excellence in Teaching Award at the Wayne State University. She has also been consistently recognized at the Top Doc Detroit Doctors. And then she has also been invited to edit a Pediatric Annals journal. And this had covered all the topics in pediatric nephrology. And this was a few years ago. She has recently been inducted to the National Academy of Medical Educators, and that shows her strong skills as an academic pediatrician and a pediatric nephrologist. And on a personal note, I can share with all the viewers and attendees that she is very much interested in training pediatric nephrology fellows as a director of the Pediatric Nephrology Fellowship Program. And I can tell you that she is always looking for young minds, young trainees. So anybody who's interested, please do contact her after the lecture. So over to you, Dr. Rosanna Baracco.
Thank you so much for that introduction. And it's my pleasure to introduce our first speaker, Dr. Pankaj Hari. He's a professor of pediatrics, a pediatric nephrologist in the Division of Pediatric Nephrology at the All India Institute of Medical Science in Delhi. His particular interests are in urinary tract infections, in vesicular urethral reflux, and in nephrotic syndrome. He completed a fellowship from the International Society of Nephrology at Cedars-Sinai Medical Center in the USA. He has been the secretary of the Indian Society of Pediatric Nephrology from 2001 to 2009. He currently serves as counselor for the International Pediatric Nephrology Association. He has 3 decades of pediatric nephrology experience and has mentored numerous pediatric residents. And he has published more than 100 original articles, case reports, review articles, and book chapters. And the title of his topic today is Urinary Tract Infections, an update. And we're very excited to have you with us, Dr. Pankaj, and you can go ahead and start your presentation.
Thank you, Rosanna, for a very extensive introduction. And it's my pleasure to be delivering a talk in this webinar. And I shall be talking about urinary tract infections in children. And this is going to be an update. What I'm going to do is that I'm going to be talking about the new Indian Society of Pediatric Nephrology guidelines, which have come up in 2023. It's under publication. It has taken about 2 years to complete the guideline. And while this is a revision of the old guideline, which was developed in 2011, but this guideline is quite different because of its methodology that it has followed. So this is the overview of my talk. I will be talking briefly about why these guidelines are different and what kind of methodology we have used. And then I'll be speaking on the specific statements pertaining to diagnosis and therapy of UTI imaging studies after the sort of a UTI, recurrent UTI, bladder bowel dysfunction, and also in the second part about vesico-ureteric reflux, about its treatment, the role of antibiotic prophylaxis, and finally the relation between vesico-ureteric reflux and end-stage kidney disease. So this is one of the few guidelines that actually covers vesico-ureteric reflux along with urinary tract infection, because most of the guidelines on UTI, they only talk about UTI, and most of the surgical society guidelines will talk about the vesico-ureteric reflux. But we now know that VUR is chiefly managed medically, and that's why an Indian Society of Pediatric Nephrology has dealt extensively on VUR in these guidelines. So these guidelines pertain to UTI as well as primary VUR, and we exclude UTI in complex abnormalities, such as obstructive uropathy and neurogenic bladder. And the important aspect of the guideline is that we had an evidence review team that performed systematic reviews, and multiple in fact. So we performed 9 new systematic reviews and also updated 7 existing ones. So we carried out a rapid update of those systematic reviews where information was already available. And then we created the evidence profile and rated the quality of evidence for each and every outcome. And then we followed the grade methodology for formulating recommendations from the evidence that we collected. It conforms to the international standards. And if you go by the AGREE checklist or the international IOM checklist, which is a guideline for transparency, rigor, and thoroughness of the guidelines. So it takes care, I mean, it has dealt, we have taken care of all the domains that these checklists provide for before we formulate a guideline. We have 19 clinical practice points and 16 recommendations formulated. And we obtained more than 80% consensus among the guideline group for each of these statements. And we have also undertaken an external review of the guidelines, which included 9 international and national reviewers. So we have given statements in 2 forms. One is called the recommendation, the other is clinical practice point. Wherever a systematic review was conducted and there was ample evidence, and the evidence showed clear preference of one action over the other, these are given as recommendation. These are guidances which are actionable. And each of these statements is supported by the quality of evidence, the balance of benefit and harm, values and preferences for that particular intervention, and also the acceptability and feasibility of whatever recommendation we're giving. Whenever there was insufficient evidence or the evidence was inconclusive or a note, or we have not conducted a systematic review, we have given this as statements as clinical practice point. These are guidances, chiefly in the form of tables, figures, and algorithms. So first, about the diagnosis of urinary tract infection in children, and the issue is chiefly about the pre-continent children, and the guideline panel suggests that we use clean catch method for urine collection in toilet-trained children. However, in pre-continent children, clean catch should be attempted initially. If it is unsuccessful, catheterization or suprapubic aspiration can be used. On the other hand, if it's in case of a sick infant, catheterization or suprapubic aspiration should be preferred. We know that we have good screening tests available for making a presumptive diagnosis in a high-risk patient who is suspected to have a UTI. And we have these rapid tests available in these days, glucoside-esterase and nitrite. And while we know that these tests individually have low sensitivity and specificity for diagnosis of UTI, but if you combine the two together, they have reasonable sensitivity and specificity. And we carried out, we in fact updated this meta-analysis of 2007, which was used by the NICE guideline, and we updated it till 2020. And we found that, in fact, the combination of glucoside-esterase and nitrite was reasonably sensitive and specific for making a diagnosis, yet it did not replace urine culture. So the guideline panel suggests that one can use glucoside-esterase and nitrite as combination as a screening test. Whenever feasible, one can also, one can even use the microscopy for bacteria as well as pyuria in a freshly voided specimen. So, but this, we know that it's more cumbersome in an emergency unit, and therefore easily for microscopy of WBCs, one can replace it by leukocyte esterase. So this is an approach which has been suggested in the guideline for making a diagnosis of UTI. While these guidelines mention that the age categories below 18 years, we chiefly focus this algorithm for young infants, those who are less than 24 months of age, who have fever without focus for more than 48 hours, whether in the presence or absence of risk factors. And for older children who have specific urinary symptoms, we suspect UTI, and one should then perform a urine culture and dipstick test. If either of the tests is positive, one can start empirical antibiotics. If both of them are negative, but the child has risk factors and the age is less than 6 months, one could consider using empirical antibiotics, but only after sending the urine culture. If there are no risk factors and child is older than 6 months, one can send the urine culture, wait for the culture report. In case you've started empirical antibiotics and the culture turns out to be positive, you can continue with the same antibiotics if there is a good clinical response. On the other hand, if the culture turns out to be sterile, then you could think of other diagnosis. And in case if you had not started antibiotics, then if the culture turns out to be positive, then you should begin antibiotic therapy. Now, there's been some debate about the colony forming unit definition for diagnosis of a urinary tract infection in the clean catch urine. The definition is really old, actually, and it's been based on studies which have been conducted about 50 years back. So the cutoff of 10^5 colony forming units has come from adult studies, and in fact, there have been multiple studies that have looked at paired sampling through the suprapubic aspiration as well as clean catch, and they did show that about 10 to 25% of younger than 2-year-old children had clean catch urine showing colony forming units of less than 10^5, with the suprapubic aspiration being positive for UTI. And other studies have also found that there are similar rates of scarring and the congenital anomalies picked up after a episode of UTI when you use a lower cutoff as opposed to the cutoff of 10^5. So the guideline panel suggested making a diagnosis of significant growth of single bacterial species in the presence of symptoms. For these suprapubic aspiration, more than 10^3 colony forming units. For the catheterized sample, more than 10^4, and for the clean catch specimen between 10^4 and 10^5. So there is some bit of flexibility. If your index of suspicion is high and the child it's in a young infant, you could still consider lower colony forming units for making a diagnosis for UTI. Now, we are all aware of asymptomatic bacteriuria, and we again looked at the evidence, and most of the studies were done quite old, done in 70s and 80s. And it's defined as the significant colony forming unit grown in an asymptomatic patients, chiefly seen in adolescent girls. Interestingly, half of, meta-analysis which were recently conducted in 2020 and published, half of these patients have also shown presence of leukocyturia. So the very fact that WBCs are present and that excludes, and that's a marker of inflammation and should exclude asymptomatic bacteriuria is not true. In fact, if the patient is completely asymptomatic, then it should be still taken as asymptomatic bacteriuria. And therefore, the guidelines suggest not to perform routine urine cultures after the treatment of UTI, because what you'll pick up these kind of patients, if there has been a good response, is asymptomatic bacteriuria in case the culture turns out to be positive. And the guidelines are very clear that one should not be treating asymptomatic bacteriuria because the risk of renal scarring and the renal growth in treated and untreated patients are not different. And there is a risk of development of symptomatic infection in those who have been treated for asymptomatic bacteriuria by more sinister organisms. So at best, it is avoided. As far as treatment of UTI is concerned, the guideline recommend use of oral antibiotics for febrile UTI or acute pyelonephritis, except if the infant is less than 1 month of age, or a child has suspected to have bacteremia or sepsis, or in those children who are unable to ingest the antibiotic therapy. So in those situations, we suggest using IV for initial 3 to 4 days till defervescence, and then this should be followed with oral antibiotics. Since there is a concern in the category of 1 to 3 months, the guidelines suggest a clinical practice point that one can consider using intravenous antibiotic to treat acute pyelonephritis in children who are in this particular age category. The drug recommended for treatment, because these are is the 3rd generation cephalosporin or amoxicillin clavulanic acid combination, and as an empirical antibiotic therapy, these have been used in most studies. That's why, on the other hand, you should also consider the local cultured sensitivity pattern when you're treating UTI in your region or your center. As far as treatment duration is concerned, there was sufficient evidence for the lower UTI or cystitis, where short courses have been shown to be as good as long course therapies, and therefore this is a strong recommendation that you could use a short course therapy of 3 to 5 days for the lower tract infection. On the other hand, there isn't enough evidence to suggest whether a 5-day or a 10-day or a 7-day therapy of antibiotic treatment will suffice for a febrile UTI or acute pyelonephritis. So therefore, the guideline suggests a clinical practice point using 7 to 10 days of antibiotic treatment. And we had a recent SCOUT trial which was conducted in the US, which failed to show non-inferiority of 5-day therapy as opposed to 10-day therapy, and it still needs to be shown whether 7-day is as good as 10 days. That's why this is left a little flexible between 7 to 10 days of antibiotic treatment for a febrile UTI. So this is, in summary, the algorithm for treatment. Cystitis, which should be considered only in adolescent children, shorter course of treatment, it should be 3 to 5 days. For febrile UTI, or in a child who is younger than 2 months, suspected of sepsis, renal language tenderness, poor oral intake, consider giving IV antibiotics for a short period of initial 3 to 4 days. Good clinical response, change to oral antibiotics. On the other hand, if these are not present, then you can straight away use oral antibiotics. If there is a good clinical response, you don't need to repeat a urine culture. And in case if there is the response is unsatisfactory, then a culture should be repeated, and also an ultrasound is recommended. So this is so now once the UTI is treated, how should the imaging be carried out? Because what we are interested to find out is an underlying congenital anomaly of the kidney and urinary tract, and the most common such diagnosis is a primary VUR, which is associated with the an episode of a urinary tract infection. And while the guidelines are very aggressive in carrying out investigations in the past, in the last 5 years, if you could see, or maybe the last 7 years, most of the guidelines have actually minimized the number of investigations after the episode of UTI. And you could see that most of the guidelines would prefer doing an ultrasound in a patient with UTI, accepting the NICE guideline, which said only in children less than 6 months. Most of the guidelines would say do it in all children who had a UTI. For MCU, most of the guidelines would say that if it's a recurrent UTI, some of the guidelines, Italian guidelines would say even the non-E. coli UTI, Swiss guideline would say atypical UTI, you could consider doing an MCU. And about the late DMSS scan, the American Academy of Pediatrics doesn't recommend any DMSS scan. However, the NICE guidelines, they say recurrent UTI or atypical UTI, you should look for scarring using a DMSS scan. The Italian Society suggests doing DMSS scan for renal scarring in those who are having a high-grade VUR, which is 4 or 5. So I'll tell you the recommendation by the Indian Society of Pediatric Nephrology. So let's look at the imaging that are available after an episode of a UTI, and the imaging study that is required in all children is an ultrasound. So it should be carried out in all children after an episode of a UTI. And if there are abnormalities that suggest there's an abnormal ultrasound which may suggest an underlying VUR, then an MCU should be performed. And these findings include renal hypoplasia, either unilateral or bilateral, abnormal renal echogenicity, presence of hydronephrosis, ureteric dilatation, bladder anomaly. And in those children who have UTI and there is urosepsis or a non-response, what we call as an atypical UTI, renal dysfunction, there an early ultrasound should be carried out to pick up complex abnormality of the urinary tract as well as any renal abscess. What about the other two investigations? The dimer camptosuccinic acid scan, which is look for photopenic area or acute inflammation, as well as when it's done late, you pick up scarring, which is a permanent scar in the kidney. Now, there's been a time when, in fact, early DMSS scan was been favored as a top-down approach for minimizing the number of micturating cystoscopy. However, of late, the results show that the data doesn't favor DMSS scan because of its very poor specificity. So in case, even if a child has a photopenic area in the early DMSS scan, the chances that he would have an underlying VUR is just about 50%. So therefore, early DMSS scan done within the first 2 weeks is not recommended. And the guidelines say that do not perform an acute phase DMSS scan in children with febrile UTI, although this is a weak recommendation. As far as the late DMS is concerned, there wasn't good quality evidence, and therefore the panel suggested that we can give a clinical practice point of performing a late DMS scan to assess kidney scarring in those children who have recurrent UTI or a high-grade VUR. Now, the ISBN guidelines have defined high-grade VUR as 3, 4, and 5 because most studies that have been carried out have included 3 and 4 as a high-grade VUR. And you would know that most of the studies on antibiotic prophylaxis have actually in the initial phase excluded grade 5 VUR. So what are the indications of doing a micturating cystoscopy? And the guidelines suggest performing MCU in children with any one of the following. The child is less than 2 years of age with a non-E. coli UTI. There's an abnormal ultrasound scan, or there are recurrent UTI defined as more than 2 episodes of febrile UTI. So this is a summary of a summary approach for imaging after UTI. All children should be assessed for bladder bowel dysfunction, and of course this applies to the toilet trained children because you can't assess very young infants for the bladder dysfunction. Ultrasonography is recommended in all. If it's abnormal, MCU is indicated. If you have recurrent UTI or a non-E. coli UTI in less than 2 years of age, MCU is recommended. If you have a high-grade VUR, then late DMSS scan at 4 to 6 months. If recurrent UTI, again, the guidelines suggest that you should be doing late DMSS scan for scarring. Now, there's been a very close association between recurrent UTI and bladder bowel dysfunction. And we know, and we have carried out meta-analysis where we found that it is closely associated with VUR and recurrent UTI. It's an independent predictor of a UTI, delays resolution of VUR. And also, if it's corrected, it also results in downgrading of the grade of VUR. So the guidelines suggest that all children with UTI should be evaluated for bladder bowel dysfunction. Of course, the toilet trained ones. Prophylaxis should be given in recurrent febrile UTI and bladder bowel dysfunction, irrespective of the presence or absence of VUR. And this has come from the evidence that the prophylaxis has been shown to be beneficial in the category of patients who have bladder bowel dysfunction. So now moving on to primary vesicular reflux, the guidelines will cover as to how it should be treated. And just to give you a brief history that in 80s and 70s and 80s, it used to be considered as a very sinister disease, and one would be doing a surgical correction upfront in all patients. And it was only after the landmark Birmingham trial and the international reflux study that by turn of the century, and these studies showed that patients who were treated surgically or versus medical treatment in the form of low-dose antibiotic prophylaxis, there was no difference in terms of outcomes of recurrences of UTI and renal scarring. And therefore, by the turn of century, it became the medical therapy of low-dose antibiotic prophylaxis became the cornerstone of treatment for primary vesicular reflux. However, this was also questioned in the last 2 decades. We have multiple trials and more than a dozen trials which have examined whether low-dose antibiotic prophylaxis is good enough against no treatment or placebo. And there are 3 important low risk of bias trials, the randomized controlled trials, which need mention here: PREVENT trial from Australia, REVO trial, which is from the US, and the Indian trial as well, which we carried out at the Institute. And based on the result of these low risk of bias studies, the evidence for antibiotic prophylaxis in the treatment of VUR has been shaped. In addition, we have two others treatment. The uretrectomy implantation has stayed as a gold standard treatment for correcting the VUR. And the other important and interesting treatment is the endoscopic treatment, where you inject bulking material at the VU junction, and which has also gained because it's minimally invasive, so it has become it's been favored by particularly by urologists. However, it again, as you will see that in form of evidence, it doesn't offer any benefit over medical treatment. So if you see how antibiotics prophylaxis compared with surgery or endoscopic injection, meta-analysis have clearly shown that there is no difference in renal scarring at 5 and 10 years. The risk of recurrence of symptomatic UTI is similar. However, there are less number of febrile UTIs after surgery. If what if there is a renal scar already present, or if there is a CKD present with a VUR, should surgery be useful? Surgery has not shown to prevent even the progression to ESKD. The percentage change of GFR was also found to be similar in those who had renal scars and renal dysfunction. And majority of reflux we know that they improve spontaneously over a period of while the child grows beyond 10 or 12 years of age. Again, endoscopic treatment, it again offers no additional benefit over prophylaxis. So how about prophylaxis in VUR? And if you look at this plot, when we do segregated trials for the high-grade VUR 3, 4, and 5, and what we found was if you combine all these, the pooled estimate marginally favored the role of antibiotic prophylaxis in preventing UTI in high-grade VUR. What about prophylaxis in the normal urinary tract? If you look at the various studies and look at this forest plot, you can see that the pooled estimate does not favor the role of antibiotic prophylaxis in prevention. And therefore, the guideline panel has suggested against using antibiotic prophylaxis for prevention of UTI in children who have normal urinary tract. So for high-grade VUR, prophylaxis is recommended in those who have high-grade VUR. And the suggested drug is a cotrimoxazole or nitrofurantoin as the first-line antibiotic therapy in children older than 6 months, because these are the two drugs which have been most often used in clinical trials for prophylaxis. There are two clinical practice points which say that one can use prophylaxis also in low-grade VUR in an infant who's been diagnosed the VUR after febrile UTI. And again, there isn't enough evidence to support the statement, yet this is an area of concern, because in an infant VUR and a UTI, one would consider giving it for a short period. We suggest that the antibiotics can be discontinued, prophylaxis can be discontinued in children who are older than 2 years if they become toilet trained, there is absence of bladder bowel dysfunction, and there have been no febrile UTI in the last 1 year. So this is as opposed to the previous guidelines when we used to say that it should be continued at least 5 years. How are these guidelines comparing to the guidelines, the other guidelines? And if you look at the other guidelines from 2015 onwards, the surgical guidelines would say that yes, it can be used for dilating VUR as well as bladder bowel dysfunction. Korean Society says no prophylaxis in any of forms of any grade of VUR. American Academy of Pediatrics doesn't provide any recommendation on prophylaxis. The Italian Society of Pediatric Nephrology says that yes, it can be used for high-grade VUR only 4 and 5, and also those with recurrent UTI. The Swiss guidelines would also say that for high-grade VUR, yes. The Indian guidelines also say for high-grade VUR as well as bladder bowel dysfunction, and also for recurrent UTI. So generally, most of the guidelines are saying the same things. As far as renal scarring is concerned, you look at the data and you find that the meta-analysis have shown that none of the studies showed actually a benefit of antibiotic prophylaxis in preventing renal scarring over a 1 year period or 2 year period. And the pool estimate also shows that there is no benefit. So this is a question, an important question, that why has renal scarring remained unchanged? And then people have thought that is it the host inflammatory response that is already there when you begin the antibiotic treatment that leads to renal scarring, and it is not affected whether you are not able to prevent it. So because when these patients have a UTI, and so they thought of using corticosteroids for blunting the inflammatory response. And there have been at least 3 trials. The last one was in 2020, which was a reasonably large study, and it failed to show a benefit of use of corticosteroids simultaneously with antibiotic therapy. The previous 2 studies also did not show a benefit, but if you combine the data, interestingly, while this is a very small number of patients overall, you find that there is some kind of a benefit, but this evidence is insufficient to recommend its use in clinical practice. As far as antimicrobial resistance is concerned, there is clear data to suggest that when you use antibiotic prophylaxis, the UTIs that develop in these children are very often multi-drug resistance. And almost all of the studies and the pooled estimate shows that there's a clear harm when you use antibiotic prophylaxis. While the infections to other organs, or it doesn't make you immunocompromised or you start developing infections of lungs and other areas, but the urinary isolates, they do develop antimicrobial resistance and the gut flora as well. So that's why it's important to look at this harm against the marginal benefit when you consider using antibiotic prophylaxis for patients with PUR. So therefore, there's a need to look for some kind of a non-antimicrobial alternatives for prevention of UTI. And interestingly, last 20 years, there's a compound which is available, which has been first tested in adult women. This is the cranberry, which contains proanthocyanidin, which is a large polymeric compound, which inhibits bacterial adherence to the ureoepithelial cells. In children, there are multiple studies in those with recurrent UTI where there's been some benefit. There is not enough data in vesico-ureteric reflux. And very importantly, that one has to know that an particular amount of proanthocyanidin is important to be ingested to prevent a UTI. Now, there are extracts available, but then the exact active ingredient sometimes may not be available. If you look at the meta-analysis, it does show that in normal urinary tract, if you combine all the studies, there is some kind of a benefit. Again, you could argue that this is not good enough evidence, and that's why it's a weak recommendation that you can consider using cranberry products for prevention of UTI in children with recurrent UTI. This is against the backdrop that there is no harm of antimicrobial resistance when you use cranberry. Circumcision, these are all old, this is an old meta-analysis and the evidence remains the same. There isn't much of randomized controlled trial evidence. Whatever has been there, it has failed to show any clear benefit. However, there is some benefit of a circumcision, and the guideline panel suggested that it can be offered for prevention of UTI only in children at risk, which means those children who have high-grade VUR, particularly in the infantile period. For treatment of VUR, prophylaxis is the first line for management of high-grade VUR. Surgical reimplantation should be considered in high-grade VUR with the recurrent breakthrough febrile UTIs on prophylaxis, which should at least be more than 2. We suggest that open reimplantation be preferred. However, patients should be given option of minimally invasive endoscopic treatment by clear guidance from the physician that it is minimally invasive in nature, but also has a lower success rate as compared to open reimplantation. And regarding parental preference also, there is a suggested point, a clinical practice point, that in high-grade VUR, if the parents are not ready to use antibiotics, then one can consider doing a surgical intervention. So this is a summary of how primary VUR should be treated. Low-grade VUR, no UTI, no prophylaxis. There's bladder bowel dysfunction present. You can use antibiotic prophylaxis till its resolution. High-grade VUR 3, 4, and 5. Use antibiotic prophylaxis till the age of 2 years, or at least 1 year from the last UTI, and also the bladder bowel dysfunction should have resolved. In case if there is no bladder bowel dysfunction, but you continue to have recurrent UTI on antibiotic prophylaxis, then there is a need for and consideration for ureteric implantation or endoscopic injection. How about the risk of end-stage kidney disease with this congenital anomaly, primary VUR? It has stayed almost constant over last, in fact, 30, 40 years based on various registries, and the risk is about 5%. So this is chiefly because most of the ESKD that happens or develops in primary VUR patient is the one which is associated with congenital dysplasia, and that you can't change. So if you look at the evidence in terms of for large follow-up cohorts, They did not find any CKD if there was a normal DMS scan and diagnosis. If kidneys are clean, you will not develop a CKD despite the fact that you have high-grade VUR. While if you look at the mix of VUR patients, then you might find that the ESKD incidence is about 5%, 3% may develop hypertension. Overall, the risk is pretty small, given the fact that the prevalence of VUR can be very high. A lot of VUR may be asymptomatic. So who are the patients of VUR who need follow-up? Those who have developed scarred kidneys or have associated scarred kidneys, they need long-term follow-up like CKD. Screening, well, the guidelines suggest that you could consider screening in children who are younger than 3 years of age with ultrasound only. Ultrasound can be used to monitor renal growth in high-grade reflux and those with scarred kidney, but not very frequently. DMSS scan, there is no need to repeat it, can only be repeated only if there is a recurrent febrile UTI. MCU, again, no need to repeat unless until a surgical intervention is planned. And if sometimes parents are apprehensive with a high-grade VUR and would like to see the resolution of reflux, then you could consider doing a DRCG, which is the radionuclide cystourethropy. But then again, it should be carried out much later because we know that the resolution of a high-grade reflux takes much longer time, usually 10 or 12 years of age. So this is how the guidelines have changed. In 11, the guidelines were not graded as recommendation and statements. This is now quite evidence-based. It conforms to the AGRI and the Institute of Medicine checklist. The colony forming units have been, there is some kind of leverage that's been given to low colony forming units also, particularly in infants. Treatment has been shortened to 7 to 10 days. The previous guidelines of ours mentioned 10 to 14 days. Acute DMS scan was not mentioned in 2011 guidelines, and we clearly mentioned in this guideline that it's not recommended. So top-down approach is being given up. The late DMS scan is only recommended for high-grade VUR. Previously, it was all forms of VUR and also in those with recurrent UTI. MCU, previously we mentioned about 10 years back that all children who are younger than a year old should require an MCU. By now, we say that it should be done if it's there is non-equal UTI in younger children. And while normal ultrasound recurrent UTI still stay as indications for doing MCU. Prophylaxis is the duration is shortened now, and we can stop till the child is toilet trained. Previously, we used to be giving it for 5 years or so. Prophylaxis, again, it was mentioned that while awaiting evaluation and you suspect a VUR, you should use antibiotic prophylaxis and use it in all VUR. Now we say that it should be used only in high-grade VUR and not in those who have normal tract. So awaiting investigations, no need to give antibiotic prophylaxis. And in the previous guideline, we did mention that if there is deterioration in renal function in a patient who have VUR, you consider doing surgical intervention. However, there is no such evidence, and that's why the current guidelines do not use it as an indication. So to summarize, the new Indian Society of Pediatric Nephrology guidelines are well updated, have followed a very rigorous methodology, and they are applicable across regions. What we now say is a lower colony forming unit may be sufficient in young infants. The post-UTI imaging has become very selective and less aggressive. There's a lot of emphasis on bladder bowel dysfunction, because this is one of the risk factors that is associated with recurrence. Surgery and prophylaxis are similar, and the indications of surgery are very limited. Prophylaxis should be considered in high-grade in high-grade VUR, recurrent UTI, while you should be aware of the risk of antimicrobial resistance that can happen with the use. And there is a need to look at the non-antibiotic intervention. So there is a need to study things like cranberry extract. And so we need large randomized controlled trials to find out any other effective treatment which doesn't cause any harm in preventing recurrent UTIs. Thank you very much.
Thank you, Dr. Pankaj. That was an excellent presentation. And now it's my pleasure to introduce Dr. Sunil Reddy for the next presentation. And I invite all participants to please write your questions in the Q&A box, and we're going to do the questions at the end of this next presentation. So go ahead and write your questions there so we can have that discussion later. So our next presenter is Dr. Sunil Reddy. He's a pediatric nephrologist, a senior registrar in the Department of Pediatric Nephrology at Dr. Mehta Multi-Specialty Hospital in Chennai. His interests are in acute care and interventional pediatric nephrology, and he will be talking to us today about the syndromic associations of CAKUT and its clinical implications. Thank you, Dr. Reddy, for being here and for your presentation, and you can go ahead.
Thank you, ma'am. So today I'll be talking about CAKUT, its syndromes and its clinical application. So my order of presentation today will be the definition, certain terminologies, what are the different classifications, incidence, etiological factors, CAKUT associated with different systems, CAKUT in chromosomal anomalies, examples for each type of phenotypic CAKUT in different syndromes, some associations and sequences in syndromic CAKUT. How do you approach a syndromic case and with the genetic counseling, and certain examples of certain cases. So what is the definition of CAKUT? CAKUT is broadly categorized as both structural and functional abnormalities of the kidney, the collecting system, bladder, and the urethra. The in-depth, a little more broader definition will be the developmental abnormality of renal parenchyma, the lower urinary tract, urinary collecting system, and the disrupted embryonic migration of the kidneys. So some important terminologies which you should know in syndromic CAKUT is malformation. Malformation is basically a structural anomaly where there is the anomaly is because of the abnormal developmental gene. The second one is the disruption. Here the gene is proper, but there is a destructive influence of a particular factor which happens during the development, because of which you have a structural anomaly. For example, maternal use of cocaine. Cocaine is actually a very powerful vasoconstrictor. So maternal cocaine usage can lead to bilateral or unilateral renal hypoplasia and even abnormal abdominal wall defects. The deformation, the gene is proper, and there is a mechanical influence somewhere along the development of the kidney. And that is why there is a structural anomaly. For example, oligohydramnios sequence or any obstructive sequence which happens, this is a deformation. In dysplasia, the genome initially is all right. Because of certain epigenetic factors, it alters the thing, and that is why you have a structural anomaly. For example, methylation should actually stop the codon, but that does not happen, and that is why you get dysplastic kidneys. So the malformation examples are renal hypoplasias and dysplasia. Deformation, it's because of any oligohydramnios, and it can predispose to deformation. You can even have CTV is also in that. Example is Potter sequence. Disruption, like I have mentioned, maternal cocaine leads to unilateral abnormal kidney and abnormal wall defects. Dysplasia, and it's a structural anomaly. It can involve one or more organs, and it evolves over time. Certain other definitions: a sequence is a cascade of abnormalities that will result because of a single initiating anomaly. Example is Potter sequence. A syndrome is a consistently observed pattern of anomalies found in an individual. It can be malformation, deformation, or disruption. For example, Down syndrome. An association is a constellation of anomalies that occur together more often than expected, but it cannot be explained by a single cause or any sequence of events. So it does not represent a sequence or a syndrome definition wise. For example, Vactral association or charge associations. So the classification of CAKUT, basically according to today's topic, the broad classification will be into two categories, which is syndromic and non-syndromic. The non-syndromic CAKUT generally is limited to the kidney and the lower urinary tract. The syndromic CAKUT, it can involve both the upper and the lower, and involves other organ systems also. Example, horseshoe kidney can be a part of syndrome in which there is Turner syndrome. Example, it can involve other systems, and it can be a non-syndromic presentation where it is only manifested as an isolated horseshoe kidney presentation. 60% of Turner syndrome children are supposed to have a horseshoe kidney presentation. So another way of looking at it is the syndromic CAKUT, if it is associated with different organ systems. The organ systems which can be involved are genital, neurological, cardiovascular, anorectal malformations, muscular defects, intestinal anomalies, and even bone deformity. According to this study, the most commonly involved is genital system, but it can vary in different places according to differently. Based on the phenotype of the syndromic CAKUT, there is a broad spectrum, and the phenotypes can involve renal agencies, multicystic dysplastic kidney. These both together form the maximum chunk of syndromic CAKUT. The other ones which can be involved are uretropelvic obstruction, duplication of pelvis, ureter or kidney, uretropelvic junction obstruction, VUR, posturethral valve, congenital megaureters, bladder and urethral abnormalities. These phenotypic CAKUTs, it depends upon the insult which happens along the development of the kidney during what period of embryogenesis. For example, if there is an insult which happens before 4 weeks of the embryogenesis, then you can have kidney agenesis. So these are the definitions of each of the phenotypes. Renal agenesis, unilateral or bilateral, where there is kidney and outflow system which they fail to form. Hypoplasia is either unilateral or bilateral, where the shape is abnormal, but the size is smaller and a reduced number of functions. The dysplasia is that there is shape, tissue differentiation, and abnormal number of nephrons. This is the difference between hypoplasia and dysplasia. Multicystic dysplastic kidney, you have multiple cysts in a dysplastic kidney and it gives an abnormal shape. Horseshoe kidney, it is fused kidney when there is ascension of kidney which is going up. If there is any block in it, it will stay back in pelvis. So that becomes an ectopic pelvic kidney. It can also reach the thorax, but it is very, very rare. Uretropelvic junctional obstruction is the obstruction between kidney and the ureter. Vesicurate reflux is unilateral or bilateral reflux of the urine from the bladder into the upper system. Duplex system is upper or bilateral duplication of the ureter, kidney, or the pelvis. Megaureter is unilateral or bilateral dilatation of the ureter, resulting in defects in the urine outflow. Posturethral valve is a membrane which obstructs the urethra and prevents the outflow. So this is a pie chart which actually shows the incidences of the different phenotypes which present. The most common being renal agenesis, and the second most common being the multicystic dysplastic kidney. So these both entities form the major part of the phenotypes involved in a syndromic CAKUT. So I have put the slide in which there is phenotype, what kind of, what is the gene which is involved, and what syndrome is it named after. In JAG1 mutation, which is the most common mutation in Alagille syndrome, you can have cystic kidney disease along with paucity of bile ducts. Bronchio-otorenal syndrome, the abnormality is in EYA gene and 6-5. PAX2 is the most common gene which they have found in syndromic CAKUT, and it causes papillary renal syndrome. The Meckel-Gruger syndrome, most of us would have seen those pictures anywhere in neurology textbooks or pediatrics, where you see encephalocele. Most of these babies have MKS1 gene abnormality and they hardly survive. These are some numbers. The true incidence of urinary tract anomalies is very difficult to ascertain because most of the anomalies are asymptomatic and they go undetected. Around 23% of all the birth defects are due to CAKUT. 30 to 50% of all cases which have end-stage renal disease in children is because of CAKUT. The incidence of CAKUT was approximately around 4.2 in every 10,000 births in population in a study based in Taiwan. I've taken this study because the maximum incidence of CKD in a population is the highest in Taiwan. And they found that CAKUT is most frequent malformation and it can be detected by ultrasound in utero as early as in the first trimester. The most common anomaly they have detected is multicystic dysplastic kidney. Approximately 80 to 90% of them can be detected as early as the first trimester. And there are around 200 syndromes which have been detected, which are associated with CAKUT. This is one of the earliest studies which have been published by Barakat. He's a pathologist, he's a pediatric nephrologist from the States. He had studied around 13,000 consecutive autopsies and found the overall incidence in CAKUT was around 4.6, which had 85% involving the upper urinary tract. And out of that, 45% of the kidneys and 29% in the ureters. So this is a study done in Germany. The cohort was around 430 children who were regularly coming to the pediatric nephrology OPD. And in them, they have found that the most common incidence was renal agenesis. And in syndromic children, they had done genetic studies. So in that, they have found that the most common was renal cyst and diabetes syndrome. It is by HFN1 beta gene. So this is a slide showing the birth registry. And this is the International Clearinghouse for Birth Defects and Surveillance and Research. This birth registry is actually totally voluntary. And in this also, they have found the incidence of renal agenesis to be somewhere between 0.2 to 0.6 and cystic kidney between 0.2 to 0.5. These are the two most common things, which I have shown it in the prior slides also. India has joined the part of this registry in 2010. So it is a hospital-based and voluntary. So the cohort involves from 24 weeks up to till 1 year. And the nodal officer is Dr. Suresh, and this is his address. We can just intimate them regarding the birth defect. So the etiological factors of CAKUT, the socio and demographic factors also play a main role in CAKUT. Maternal diabetes is one of the major reasons for renal agenesis. ACE inhibitor usage in the first trimester also has shown to have a lot of renal dysplasia. Maternal cocaine use and alcohol use can cause any type of, any different type of phenotypic CAKUT. Maternal infections like syphilis, rubella, Zika, exposure to radiation, pollution, nutritional factors like folate deficiency, iron deficiency, advanced maternal age also have been found to be factors involved in syndromic CAKUT. The environmental factors, around 94% of CAKUT are seen in low and middle income countries. And it is due to nutrition, exposure to agents, poor access to healthcare and screening. Genetic factors, it can be chromosomal defects, single gene defects, epigenetic modification, and consanguinity. And unknown causes, like for all the congenital disorders, the most of the time we do not know what is the cause of that. So this is the study which shows the role of maternal factors in CAKUT. You can see different factors from low folate deficiency to vitamin A deficiency, maternal obesity, maternal diabetes and malnutrition, cocaine use, alcohol use, ACE inhibitors, and even in vitro fertilization has been found to be a significant factor in CAKUT. So this is a study showing which is published in British Medical Journal. The cohort was around 5,000 babies with birth defects. On that, 80% of them almost did not have any known etiology. So this is regarding the syndromic CAKUT. 74% of syndromic CAKUT, the reason was unknown. The most common genes which were involved in syndromic CAKUT was PAX2, which causes renal coloboma syndrome, and HFN1 beta, which causes diabetes and renal cystic disease. It was around 10% of them. 16% of them were the CNVs. On the right-hand side, we can see that out of the, in this study, which they had published, out of the 38 syndromic cases, 7 cases were related to HFN1 beta and PAX2 gene itself. Coming to the different systems which are involved in syndromic CAKUT, this study shows that multiple systems can be involved. Practically every system can be involved. The most common one being involved, according to the study, was the cardiovascular system. Around 80% of them in syndromic CAKUT has association with three systems: cardiovascular, gastrointestinal, and central nervous system. So going system wise, both renal and cardiovascular systems, they develop from mesoderm. That is the reason why they both are in association. The factor which is responsible is POD1 transcription factor, which is highly expressed in the mesenchyme in both the developing kidney and the heart. Any insult to this factor during embryogenesis can cause the defect in both the reasons. The northern blot test done for POD1 transcription factor has shown the topmost where there is expression in the heart, and the bottommost where there is expression even in the kidney. The birth registry in the northern part of Italy, Emilia and Romagna registry on congenital malformations in children with syndromic CAKUT, they have shown that there is 10 times greater evidence or incidence of cardiovascular malformations than the control patients which they had seen. This is a study published from India. 58 children with CAKUT who had a clinical suspicion of cardiovascular malformation were selected, and echocardiography was done on them. And they had found that cardiovascular anomalies were more frequently noted with isolated renal anomalies rather than the collecting system. That means the upper tract was involved more than the lower tract. And the most common abnormality they have found was ventricular septal defect. Apart from that, atrial septal defect, pulmonary stenosis, and tetralogy of Fallot, PDA, aortic stenosis were noted are also noted. So, in this study done by Barakat, the most common system involved was cardiovascular system, which accounted for around 25%, but the commonest abnormality which was found in them was PDA than ventricular septal defect. So next system is the gastrointestinal system, which formed around 18% of them, and it involved anorectal malformations, which are the most common ones, and then Meckel's diverticulum and stomach and intestine. The CAKUT wise, the phenotypes which were seen with them were abnormal ureter, hydronephrosis, horseshoe kidney, renal agencies, dysplasia, etc. So this is a cohort of Hirschsprung's disease. 106 patients were selected who had Hirschsprung disease between around 2 years period, and 20.7% had CAKUT in them. The central nervous system is the third most common system which is involved. About 10% of the patients who have CAKUT will have central nervous system anomalies. The phenotype can be renal agencies, bladder abnormalities, or horseshoe kidney. Chiari malformations and tethered spinal cord are associated with both upper and lower urinary tract in their CAKUT. So the commonest entity which will be involved is brain, which may be anencephaly. Meningocele can be there, hydrocephalus, and even spinal cord can be involved, like in form of tethered spinal cord. So 30.4% of fetal CNS defects, mostly encephalocele, are associated with CAKUT. Bilateral renal dysplasias can be associated with anencephaly, spina bifida, or encephalocele. The next system involved is the skeletal anomalies. If syndromic CAKUT has skeletal anomaly involved, it is, in a broader term, it is called as acrorenal syndrome, which involves approximately 4% of upper limbs, 3% of lower limbs, and around 4% of vertebral column, and 2% in hips and pelvis. The commonest limb defects which we can see is oligodactyly, syndactyly, and brachydactyly. This acrorenal syndrome can be a part of a bigger system, bigger anomalies like Vactral Merkel syndrome and Poland syndrome. The Next, coming to the next system, 6% of CAKUT had associated lung abnormalities and 2% with diaphragmatic anomaly. Potter sequence is associated with the respiratory system, where there is oligohydramnios. Because of that, there is thoracic compression, there is decreased fetal breath movements, and finally leading to pulmonary hypoplasia. This sequence is called the Potter sequence. If this oligohydramnios is because of renal agencies, then it becomes Potter syndrome. If the oligohydramnios is because of any obstruction, then it becomes a sequence called obstructed sequence. Along with the movements and thoracic compression, it is also found that renal protein abnormality was detected. It was decreased in values. So this resulted in the abnormality of the lung development. This was first published in 1979 in the paper, The Lungs in Congenital Bilateral Renal Agenesis and Dysplasia. So this is Dr. Potter, and she has described the sequence and the syndrome in this Potter's pathology book. She's actually a pathologist. She has also described classification for cystic diseases also, initial classification. So 7% of children have syndromic CAKUT have facial involvement in the form of cleft lip and cleft palate, which are the most common. Insult around 5th to 8th week may result in urogenital auditory, even the hearing system, because both of them develop at the same time. So the severity of the auditory system defects often is in parallel with the thing of the urogenital system. Preauricular ear, spits, sinuses are the most commonly encountered anomalies. They can be found in isolation or as a part of genetic syndrome. Most of us get a doubt if we find a preauricular ear or a pit or a sinus, should we go ahead and do an ultrasound or not? So should we do an ultrasound? The incidence of CAKUT among the infants who had isolated ear anomalies was around 2.2%. It was almost the same as if it was found in a healthy unit found in these particular studies. So they concluded that the renal ultrasound should be performed in patients with isolated preauricular pits or ears or any other anomaly if there is one or more of the following. If there are any dysmorphic features, if there are any other malformations, if there's any family history of deafness or early CKD in the family, any renal malformations, any auricular malformations, maternal history of diabetes, you should do an ultrasound. If there is no history for these things, it's not really indicated. So coming to the genital system, because of the anatomical proximity of Wolffian and Mullerian ducts, any embryological defect in this area can lead to anomaly in both gonadal and urinary system. In females, it can be abnormalities in the uterus, hypoplastic uterus or absent uterus, hypoplastic vagina, ovaries, fallopian tube, and abnormal genitalia also. Males will have usually cryptorchidism, any cysts in the seminal vesicle, unilateral prostatic agencies, cystic testicular dysplasia, or hypospadias. Mullerian anomalies are they occur up to 30 to 60% of females and around 12% of children who have unilateral agenesis. So if there is a unilateral agenesis, you should be actively looking for gonadal abnormalities. Coming to multiple congenital anomalies, it's a syndromes. There are multiple systems which are involved under the single umbrella. For example, Townie-Brooke syndrome, it has anomaly which includes ear, external ear anomalies, having hearing loss, polydactyly, imperforate anus, and renal malformation. 27% of Townie-Brooke's syndrome, which is SAL1 gene defect, will have CAKUT. So the phenotype which can be involved in them is aplastic, hypoplastic, or dysplastic kidneys, multicystic dysplastic kidney, posterior valves, VURs, meatal stenosis, and hypospadias. Another common syndrome is Beck-Pitt-Friedman syndrome. Here there is an anomaly where there is somatic overgrowth in form of, and you can see macroglossia, anterior wall defects, macrosomia, ear lobes with creases and pits. 50% of Beckwith-Wiedemann syndrome will have CAKUT in the form of renal cysts, duplicating collecting system, VUR, and hydronephrosis. So coming to chromosomal aberrations in syndromic CAKUT, the incidence of CAKUT is much higher in chromosomal aberrations compared to the general population. So around 4 to 7% of infants with CAKUT actually will have chromosomal anomalies. Example, trisomy 8 and 18, 70% of them have CAKUT. Trisomy 13, around 60%. Monosomy, around 40% in Cry-Duchat syndrome. I have mentioned earlier that horseshoe kidney is the most commonly reported renal anomaly in Turner syndrome, which is accounts to around 60% of them. So any CAKUT should be suspected in all the patients whom you think have chromosomal aberrations with or without multiple congenital anomalies. So coming to different examples using the phenotype, I will be moving these slides quite fast because at the end we have a lot of cases also. So this is totally theoretical slides. Syndrome with renal agencies, it can be unilateral or bilateral. Unilateral agencies can be seen in acrorenal syndrome or Alagili. Bilateral can be seen in charge, cocaine use. Ectopic kidney seen in Beckwith-Wiedemann, Denny-Dry syndrome, fetal alcohol syndrome, or golden hair syndrome. The phenotype of horseshoe kidney can be seen in Turner's, trisomy, thalidomide embryopathy. Dysplasia and cysts can be seen in Bardet-Biedl syndrome, Johan syndrome, Joubert syndrome. Duplication of ureters can be seen in Turner's, prune belly, golden hair syndrome. Hydroureteronephrosis seen in acrorenal syndrome, Bardet-Biedl, Noonan syndrome. Posterolateral valve, this phenotype is one of the rarest. Actually, there are only 22 described systems, 22 described syndromes with PUV till date. So it can be seen in acrorenal syndrome, Potter syndrome, prune belly syndrome, bladder exostrophy, caudal regression syndrome, caudal duplication syndrome, trisomy 18. Associations and sequences in CAKUT. So different types are there. I'll go through each of them. Vector, charge, Merkus are associations. Oligohydramnios sequence and obstruction sequence I have already explained before. One more is left, which is Syndromic sequence, which I'll be explaining. So Vector association initially was only around Vater, and later cardiac and limb anomalies have been added to it. So it has got vertebral defects, imperforate anus, tracheoesophageal fistula, renal anomalies, cardiac and limb abnormalities. The phenotypes of CAKUT which can be involved are agenesis, ectopia, or obstruction. So the vector association, all these together under one umbrella can be a part of a different entity. Like trisomy 18 can have vectoral association. Infants of diabetic mothers and fetal alcohol syndrome, they can have these multiple anomalies. Charge association, 25% of charge patients will have CAKUT. Coloboma iris and retina, this is the main part of this syndrome. Having coloboma iris or retina plus any two other of this entire associations, if you have, then only you can call it as charge association. You should have minimum at least two. And the phenotypes which are involved are ectopic kidney, malrotation, dysgenesis, horseshoe kidney, hydronephrosis, or VUR. Charge association can be seen in chromosomal anomalies like trisomy 13, 18, genetic syndrome like Eppert syndrome, infants of diabetic mothers. Merkus is an association where there is Mullerian duct, genitourinary duct, kidney, and the musculoskeletal system, all three together are involved in this. The renal anomaly phenotype can be agenesis, ectopic kidney, or dysplasia. The musculoskeletal system can be rig defects, any facial asymmetry, limb anomalies, hearing loss, brain anomalies such as encephalocele and cerebellar cyst. The Mullerian duct aplasia can involve the genital system in which there is absent uterus or ovaries or vagina also. It is called as Mayer-Rokitansky-Korsakoff syndrome. There are two types in it. If only the genital system is involved, it is MRKH type 1. If the genital system is involved along with renal system and the musculoskeletal system, then it is called type 2. Syndromic, this is a malformation in which the patients will have only single lower extremity. It will be having sacral agenesis, lower vertebral defects, imperforate anus, rectal agenesis, and there will be absent external or internal genitalia. It's commonly called as mermaid syndrome. It is because of a vascular steel phenomenon. If you see this diagram, the left one is the normal one in which there are two umbilical arteries which are going and joining internal iliac vessels. On the right one, in which is seen in Syndromic fetus, which causes this sequence, there is only single umbilical artery which is going and joining the aorta, and there are no aortic branches. So anything below the insertion of this single umbilical artery, that particular part does not develop. So this phenomenon is called the vascular steel phenomenon. So this is how they look. Usually they don't make it in life. They pass off in the neonatal period only. There are only 6 or 8 cases till now which have been reported who have been alive and alive for some part of time. So this is a famous interview between Oprah and one of the Syndromic sequence child. This child's name is Silo. She was studying 5th standard at the time of this interview. Somewhere I think it's around in 2010. Sadly, after this interview, within a few weeks, she passed away. So this is the basic theoretical part of syndromic CAKUT. Now, how do we approach this case and how do we work it up? So any syndromic CAKUT or any kidney disease with unexplained unknown etiology, first we need to know whether you have a high probability of genetic disorder or a low probability. If you have a high probability of genetic disorder, like for example, family history, consanguinity, early detection, if there is any involvement of cystic congenital diseases, then you look into whether there are any extrarenal manifestations, what was the time of onset of these manifestations. This is one part. The second part is it only involving the kidney? So either ways you will be doing exome sequencing. Once you get the reports, you have 3 different reports which can be there. One is either it's positive, negative, or variants with unknown significance. If it is positive and you have clinical presentation showing that it is a part of this syndrome, then you can go ahead directly with the genetic counseling. If it is not, then you can have a discussion with the geneticist or a pediatric nephrologist and review the result. Then if it is either negative, or if you are strongly having a suspicion of your genetic diagnosis, but it is negative, then maybe that particular syndrome has not been there, or the genetic abnormality has not been reported in the database. So this database keeps updating very regularly. So we need to keep an eye on that and regularly review it. And also you can consider any mosaicism, or you can go ahead further and do a genomic sequencing to check the gene exons and the mutations which could have been missed by exome sequencing. If you have already done that, you can do a reanalysis later part of life. So is genetic counseling important? Why is it? Basically, the genetic testing will tell us the risk of recurrence and the availability of prenatal diagnosis if it is for the next pregnancy. Majority of CAKUT, it is sporadic. It cannot be explained by monogenic inheritance. That also has to be explained to the parent. The empirical risk of syndromic CAKUT is shown somewhere between 4 to 20%. If there is a proband, you should always screen the closest relatives, because 10% of them may be having asymptomatic CAKUT, and it can lead problems in further or in their next progeny. So why should you do a genetic testing? It will give you an etiological based diagnosis. It will help you identify the problem and help you in early treatment of intervention. It can help you screen asymptomatic family members, and it can help you in genetic consulting for future planning, and it will give you a better categorization of the disease into a clinical style. So in effect, it will reduce the cost. It will include the better care and the better clinical decision making. So what is the WHO advisory for this is that you try prevent the risk factors and reinforce the protective factors, which are like healthy diet, give adequate intake of vitamins and minerals, because 90% of the syndromic CAKUT happens in the countries which are having low socioeconomic status, where they don't have proper diet. Try avoid travel, whoever are carrying a child. For example, people who have traveled had caught Zika virus, and with that, they landed up in congenital disorders. Reduce or eliminate the environmental exposure to hazardous substances like heavy metals and pesticides. Control diabetes, because diabetes has been shown one factor where any phenotype of syndromic CAKUT can manifest. Decrease radiation, and especially give emphasis on vaccination. So these are the cases which I'm going to present. The first case was a 4-year-old boy born to non-consanguineous couple. He came to emergency room with bilateral carpopedal spasm and query seizure. He also had repeated events and repeated muscle twitches in the last 2 years. And on and off, he was getting calcium and D3 supplements from the local practitioner. Past history significant was that his paternal grandfather had died due to CKD. On examination, he appeared normal. He had diminished tendon reflexes in both upper and lower limbs. So investigation showed that he had hypocalcemia, vitamin D was okay, and hyperphosphatemia was there. So parathormone levels was checked, and he had hypoparathyroidism. Ultrasound showed bilateral hypoplastic kidneys with increased echogenicity. So at that time, HDR syndrome was considered, and we did an audiometry, and it showed bilateral moderate sensorineural hearing loss, and for which he was suggested a hearing aid. So the basic triad of HDR syndrome, which is also called as Barakat syndrome, is hypothyroidism, sensorineural deafness, and renal disease. Renal disease is seen in around 62% of these patients. The second one is a 2.5-year-old girl child, firstborn of non-consanguineous marriage, had come to OPD with difficulty in walking and abnormal shapes of legs. And on examination, we found that her gross motor milestones were delayed. Past history, she had recurrent LRTA needing hospitalization. On examination, she had all features of severe vitamin D deficiency. Certain syndromic features which were there were epicanthal folds. She had low set ears, depressed nasal bridge, postaxial polydactyly both in the upper limbs and the lower limb, and she was malnourished. And blood investigation showed she had hypocalcemia, vitamin D deficiency, and normal renal function tests. So these are the X-rays which we had taken for her. And the left X-ray, which is showing the chest X-ray, you can see the clavicles, which are high-riding clavicles, typically called as bicycle handle clavicles, and a bell-shaped thorax. The second X-ray is showing polydactyly. The X-ray of the lower limbs are showing short iliac bones and a triradiate pelvis. Ultrasound abdomen, which was done, showed a single kidney, which is on the right side, and it was confirmed by DMSA. Echo we had done, it showed a double SVC. This is more or less a Juan syndrome after discussion with the pediatric geneticist, because genetic tests this patients couldn't afford. So the third case is an Alagille syndrome. It's a 5-day-old male child, had history of cholestatic jaundice. Around bilirubin was around 20, and he had mild dysmorphic features. And since the parents were medical professionals, so they figured out that you need to do a liver biopsy. In the liver biopsy, they had paucity of bile ducts. Ultrasound, which was done, showed horseshoe kidney with pelvic calcium dilatation. Echo had pulmonary stenosis. Then they went ahead with genetic testing, and genetic testing found it is JAG1 mutation. Notch2 also can be there in Alagille syndrome, but the most common, around 95% of them, is JAG1 mutation. At present, he is 6 years old, and CT abdomen, you can see that there is a horseshoe-shaped kidney. And it also showed multiple enhancing nodules in the liver, contracted gallbladder and splenomegaly. And the above X-ray shows in butterfly vertebrae, which this patient had. So he is being planned for a liver transplant in future. So the fourth case is ARPKD with hepatic fibrosis. The reason why I had put this case is because in a single family, 4 children affected with ARPKD, all of them had different manifestation. So this was a 4-year-old girl. She had 3 siblings, all of them ARPKD. It was a 3rd-degree consanguineous marriage. One sibling already had died due to CKD. The difference between this child and the rest of them were that this child had features of hepatic fibrosis, but the rest of them did not have any liver involvement. So on examination, ultrasound which we had done, there were bilaterally enlarged kidneys with cyst, which were suggestive of ARPKD. CT abdomen showed hepatic fibrosis. Because she came with hematemesis, we did an upper GI scopy and it showed portal hypertension. So this is the next case, which is Bardet-Biedl syndrome. It's a 6-month-old male child with born to a 3rd-degree consanguineous marriage and uneventful antenatal checkups. Birth weight was around 3 kg. At birth, he was found to have hypospadias and left foot postaxial polydactyly. At 1 month of age, he had culture positive UTI. That time they had done an ultrasound and they found few cysts in both the kidneys. The kidneys were of normal size. He was treated normally, conservatively for UTI and sent home. At around 9 months, he started gaining weight very rapidly. So for that, the parents had come to the hospital and then endocrinology got involved and that showed obesity, microphallus, low testicular volume. He also had developmental delay in all the domains. During this time, he had an erythroplasty and he was being managed conservatively. At 3 years of age, he developed proteinuria and hypertension, for which he was started on ACE inhibitors. Currently, he is around 4 years old. He has global developmental delay, mostly in language and speech. He still can speak only 1 or 2 words. Rest of the developmental age was consistent with around a 2-year-old. Currently, his weight is around 23 kg. He is only 4 years old, which comes into the category of obese. Latest ultrasound which had done were bilaterally enlarged kidneys. It has increased echogenicity. CMD was lost. Few cysts were seen. And ophthalmology, he had difficulty in vision. So astigmatism was found. Genetic testing which we had done showed positive for CEP164 gene, problem in exon 18 and 16. So this is the X-ray which is showing the polydactyly and the kidney which is showing cysts. So this is MRKH syndrome. It is a 16-year-old girl currently. She was born to a 3rd-degree consanguineous parents. Antenatally, the scan showed that there was a right ectopic kidney in the pelvis and it had multiple cysts. At 3 months of age, ultrasound was again repeated and it showed right ectopic kidney with non-communicating cysts and the largest was 1.5 centimeter. Left kidney was showing compensatory hypertrophy. Uterus and right-sided ovaries could not be visualized. They used to do ultrasound every 2-3 years on their own. They were never on proper follow-up. At around 13 years, she hadn't attained menarche. That's when the parents were anxious. So they had come to us. That time the karyotyping done was 46XX. Fish was normal. In MRI, abdomen and pelvis, the right ectopic kidney was in the right iliac fossa with a malrotated kidney. It was hypoplastic also. There was severe uterine hypoplasia. Right ovary was not seen. So on the MCU, there was no viewer and vaginal voiding was seen. DMSA done showed left kidney was functioning 95% and right kidney almost 5%. Tanner staging was normal and she attained menarche at the age of 14. And this is a typical presentation of MRKHS type 2. Rubinstein-Tayari syndrome, 1-year-old male child, non-consanguineous parents, normal ANC. In the early neonatal period, congenital hypothyroidism was detected and he was started on medication. He also had syndromic phases and he was advised to do a genetic testing, which initially the parents did not do. Later, he had come with a UTI, which was culture positive. And that time, during the admission, on examination, it was found that he had mild global developmental delay and it was there in all the domains. Syndromic phases were there, right undescended testis and short bilateral thumbs were there. Ultrasound, which was done for it, showed a hypoplastic right kidney with increased echogenicity, but CMD was maintained, bilateral VUR and MCU. And because of all this syndromic association, we went ahead with the echo. It showed a small PDA and left to right shunt, which is in form of ventricular septal defect. Genetic testing was done later, and it turned out positive for CREB mutation. Currently, he is around 4 years old. The next case is an 8-year, 2-month-old child born to non-consanguineous parents. Mother has previous history of MTP. Preterm, this child was born preterm, normal vaginal delivery, had 2.7 kg. He was born with a single umbilical artery, high anorectal malformation, sacral adjacent polydactyly. He underwent colostomy on day 2 of life and subsequent surgeries. Ultrasound done showed right renal agencies. DMSC also confirmed the same. MRI, which was done, showed lumbarization of S1, partial sacral agencies, low-lying cord, and conus ending at L3. Echo done showed PDA and ASD. He had 3 to 4 episodes of UTI, and for which an MCU was done, which showed grade 2 VUR. At the age of 7 years also, he did not attain, he had incontinence of bowel and bladder. So the urodynamic and manometry studies showed that he had the neurogenic bladder and bowel. So this is an example of Vactral association. So Vactral association, you cannot find a specific cause. It can be, you can also find under a single syndrome, but his tests did not reveal anything. Inheritance patterns and recurrence risk can vary. It can be autosomal recessive or X-linked also. Developmentally, he is normal. And the next child who is born to this parents, it's a girl child and the child is normal. So this is another case, mitochondrial disorder, first born to a non-consanguineous parent. Mother had PIH, for which LSCS was done, low birth weight. He had failure to thrive and hypokalemia. History of certain jerky movements, probably seizure. And on examination, he had global developmental delay and hypotonia with brisk reflexes. Blood investigations had metabolic acidosis and hypokalemia, and he was already in CKD. There was an elevated lactate and CPK, and initially it was thought that this has to be a mitochondrial disorder. Ultrasound showed bilateral hypoplastic kidneys, and MRI had done because of the seizures showed Arnold-Chiari malformation type 1. MRS had showed elevated lactate, and the genetic testing was positive for TARS2 gene. And the last follow-up for this child was in 2019. And after that, we don't know what happened to him. By the time the parents had a second child who was normal. This is a brachioautorenal syndrome. It's a 1-year-old child. It is presented with bilateral low set malformed ears and difficulty in hearing. So past history, he had bronchial sinus excision. On ultrasound, right kidney could not be visualized. So a DTPA was done that also showed the decreased size and function. He had a bilateral VUR, and BERA, which was done, showed problem in conduction in both the auditory nerves. So trisomy 21. 2-year-old second-born child to a non-consanguineous parent whose mother was gestational diabetes, 2.2 kg at birth. At 8 months was found to have a developmental delay and also an hypothyroid. Examination showed the typical features of Down syndrome. Systemic examination was normal, and ultrasound showed bilateral hypoplastic kidney, and the cytogenetic showed trisomy 21. So some associations where it may or may not be a part of syndrome. 7-year-old who was a known case of VSD, closure was done at 3.5 years. And he had bilateral CTV, for which initially he had taken treatment. And they had defaulted in between. At 7 years, he had UTI. And that time there was severe phimosis, for which circumcision was done. Ultrasound done for that UTI showed the rotational anomaly, and left kidney was not visualized. So the same has been confirmed by the DMSA. Facial association. This is a 20-year-old lady with cleft lip and cleft palate, operated at the age of 1 year, and her growth had been normal. After her marriage, during her pregnancy, she developed edema and hypertension. And investigations by the time done showed she was already in CKD4. Later, she underwent cesarean section and started on HD. Ultrasound by the time showed bilateral hypoplastic kidneys and lost CMD. Currently, she is on maintenance HD twice weekly. So this is a 9-month-old female child born to non-consanguineous parents. She had complaints of urinary incontinence from birth. So she had been diagnosed with bilateral ectopic insertion of ureters with reflux and unilateral double moiety. You can see it in the right-sided X-ray. So for which reimplantation surgery was done. Before surgery, pre-op chest X-ray showed dextrocardia. After that, she had repeated episodes of UTI, and MCU still showed unilateral reflex. She was reoperated for the same, and after that, there are no episodes of UTI. Developmentally, she is normal. After that, she was been lost and follow. Again, now she has come with at 23 years old, and she is diagnosed with CKD, and she's in stage 4 with 2.2 of creatinine. The DMSA is showing that photopenic areas in multiple areas in bilateral side. So the take-home message is many renal anomalies can remain asymptomatic, and they can be undiagnosed most of the time. CAKUT may actually provide you the first clue that there is something wrong. Maybe then you should pursue it further, or at least do a complete examination, ruling out rest of the other systems. So it is very important for a pediatric nephrologist, pediatrician, neonatologist to be familiar with certain common anomalies in the kidney and the urinary system and the complex disorders. Genetic analysis will help us prognosticate and deal with the parent. And you can also involve a multidisciplinary team and try report all your anomalies to your nodal center into the database. Thank you. And my special thanks to Dr. Nammala, Dr. Vijay Kumar, Dr. Edwin Fernando, Dr. Sudha Kalaivani, Sukanya Madam, Hemchand sir, Anuke Vasu, Josna, Samjukta, Safa, Anjana, and Kavilarasu, because they were very, very instrumental in digging out the cases in the last 10 years. So my special thanks goes to them. Thank you.
Thank you, Dr. Reddy. That was a very large topic, and that was very thorough. Very interesting cases too. So now we can move on to the question and answer session. There's a few questions on the Q&A box, and if anybody has any further questions, please feel free to put them in there. First question for Dr. Pankaj Hari. How can we explain why in some infants the routine urine analysis is normal, but the signs and symptoms are positive and the urine culture is positive? I think we see this too sometimes in very young infants who present with fevers, have a negative urine analysis, no leukocytes in the urine, or minimal, maybe 5 to 10. But the urine culture is truly positive. And what do you do with those patients?
That's a good question. In fact, infants or even in other age groups also, you can have urine analysis or the leukocyte esterase and nitrite being completely negative and the urine culture is positive. And this is true because if you look at the sensitivity and specificity of the two tests, they would not pick up all UTIs, and therefore about 10% can be missed if you do not carry out urine culture. So this is something which is has to be borne in mind, that when you suspect UTI, you should always send a urine culture. If you get a leukocyte esterase or leukocytes are present on the microscopy, good, but if its absence does not rule out UTI. So in fact, when people use very stringent definition for like it was used in the RIVER trial, then they had wanted both urine culture to be positive along with the presence of leukocytes in the urine, but that is quite stringent, and you would be missing out some UTIs, and also particularly in this group, infants where this may be non-specific too.
Sure, thank you. So basically in an infant, febrile infant with a positive urinary culture, even though there are no leukocytes in the urine or a negative LE nitrates, we would treat them as a UTI. There is another question. A 10-year-old girl with first episode of febrile UTI with ultrasound suggestive of a small echogenic focus. Would we need an MCUG in this case?
This is something which is very interesting. I mean, the kind of anomalies that have been reported reported to be associated with the VUR do not include echogenic focus. And if one would like to investigate this girl further, what this echogenic focus is first, and in case it turns out to be a calculi, then you need to sort of investigate the child accordingly rather than doing the MCU. So clearly, this anomaly is not something which will suggest that there is an underlying VUR. So I would say maybe no. Then look into what is the reason for this echogenic focus and do carry out other investigations to find out the reason.
Sure. Maybe would you suggest maybe a repeat ultrasound in a few months to see if it's looking more like a stone or if it's an actual mass that would need further investigation, for example, with an MRI, et cetera. Regarding the MCU, and for example, in patients who have high grade VUR, so grades 3, 4, 5, do you, in your practice, do you document resolution of the VUR? So if the patient has done well without UTIs, they're toilet trained now, they're maybe 5, 6 years old, do you need to document resolution of the high grade VUR?
So that's again a very good question, because we do not really pursue the VUR whether it's gone or not. So we would just leave those children alone, even if it's a high grade VUR. But sometimes when the parents are very anxious as to what has happened to the VUR, in those situations, we may just end up doing DRCG. Otherwise, routinely no. One can leave the VUR even if it's high grade, because we know it will take a longer time to resolve. And if the child is completely asymptomatic, we would rather, if we have a scarred kidney or a dysplasia, then we would monitor the renal growth. Yes, I would not go for an MCU, and only if the parents are very, very anxious. Then
Okay, thank you. And Dr. Reddy, there's a question about nutrients, any specific nutrients found to be associated with CAKUT. And you mentioned that there's an association between low socioeconomic status and presence of CAKUT. Are there any specific nutrients that are known to cause CAKUT? Nutrient deficiencies, I guess, is the question.
Mostly it's about vitamin deficiencies. It's folate is known to associated with that. Even vitamin A deficiency is known to associated with that. Iron deficiency is also known to associate with a lot of congenital anomalies.
And then there's another question, which is the most common system associated with CAKUT, genital or cardiovascular? Yeah. In your initial slides, you had mentioned genital, but later with the reference to the Barakat study, cardiovascular was more common.
See, it depends upon area to area. What is there, which is common, the study which had been done in the US showed that cardiovascular system is the most common part. But the study which has been done in the Middle East, it showed that genital system was the most common for them.
Sure.
Because a lot of environmental factors also play a role in the etiology.
Mm-hmm. And when, so talking about the genital abnormalities, the gonadal abnormalities that are pretty common when, for example, you have unilateral agenesis of kidneys. When would be the best timing to do further imaging for those patients? You mentioned we always should screen for gonadal abnormalities. What would be the timing of it, and how would you screen for them? Would you do ultrasound or would you do MRI on all those patients?
Initial screening should be based on the ultrasound.
So you would start with a pelvic ultrasound?
Yes.
And is there a specific time that so if you have an infant who has unilateral renal agenesis, would you go ahead and do a pelvic ultrasound, or do you wait for the child to be older, bigger?
Usually we wait for the child to be older.
Sure. Yeah. So maybe around the puberty years, or we do the same. We wait for the child to be older.
The time MRIs are done before, if they're going to undertake any surgical procedure. Suppose if if they want to do a vaginal reconstruction surgery.
I see.
they go ahead with the MRI.
I see. You mean in younger patients?
See, we do a vaginal reconstruction surgery little on the older age group only.
Sure. Okay.
At least adolescent age.
Got it. And there is one more question in the Q&A. What is the significance of nephronia on ultrasound?
You want me to answer?
Sure. Dr. Pankaj.
So this is a term which is no longer used, in fact, and previously we used to have these terms like chronic pyelonephritis. We now know that they are actually more like what we call the reflux nephropathy, the PUR associated renal dysplasias or acquired scars. Similarly, there is a term called asthma kidney, which would be just a focal, dysplasia which is on the ultrasound. So if you're meaning that, then perhaps if it's a focal area of scarring seen, you could just you could follow these patients up for frequent renal growth and renal function. But if there is hydronephrosis, then you should certainly be looking for an underlying vesicative reflux.
Sure. And along those same lines, you mentioned the need for DMSA scan, the later DMSA, so 4 to 6 months after the UTI. You do these in patients for high-grade VUR or patients with recurrent UTIs, correct?
Yes.
And go ahead, I'm sorry, I missed that part. How does that change your management of the patients? Is it just for follow-up to, like you said, to follow up the kidney growth?
Yes, so if the patients have, let's say,
Pankaj sir, sorry to intervene. Can you stay a little closer to the mic?
Can't hear me? Can you hear me now?
Yeah.
That's better.
Yeah. So in fact, if you pick up a renal area of scarring or dysplasia on the DMSA scan, then you know that this kind of a child needs to be followed up for later for development of hypertension. When the children become adolescents, we would do an ambulatory blood pressure monitoring to find out whether they have a masked hypertension or not. And so certainly they would require sequential follow-up on in terms of like a CKT patient, we would follow their creatinines for any kind of abnormality. But if it's unilateral, then what you're more worried about is hypertension rather than CKT.
Sure. So in a child who had a febrile UTI as an infant, does not have VUR, you wouldn't necessarily need a DMSA scan. Normal ultrasound, would you do a DMSA scan in those patients?
No, that's what the guidelines say, that we don't, unless until it's recurrent UTI.
Sure. Okay, very good. I think those were all the questions in the Q&A. Thank you both very much. Very, very, very good presentations. Very thorough. It was a very interesting and fun morning.
Thank you.
Thank you, Razan.
Thank you, Pankaj sir. Thank you, Dr. Sunil. Thank you, Rosanna, for the excellent moderation. Next, we have the more interesting part. We have the polling session for the trainees. Like if you can stay back, it's still fine with us, sir. Like we have, we'll be consuming 6 minutes. So the instruction of the polling session is going to be like, I request all the participants to enter the proper email IDs. And totally we'll have 10 questions. And the given time is going to be only 6 minutes on the whole. And we'll have 3 star questions, and that will be taken into consideration only in case of tie. And only trainees are allowed to participate for the polling session. So we can go ahead with the polling session questions. Hope the polling session questions are visible. Three more minutes. Last 1 minute. Last 10 seconds.
Okay, I think that
Yeah.
that concludes the polling session. And again, thank you everybody for joining. Thank you, Dr. Pankaj, for an excellent talk and sharing all the differences in the different guidelines. That was a really very good summary. And definitely, we learned a lot out of it. Each time I hear your lecture, I always learn something new. And thank you again for your excellent talk. And Dr. Sunil, again, thank you for your very, very thorough presentation. The case series that you had was excellent. Having compiled 14 cases, and as you mentioned, this is like years and years of experience. As I was going through, you should think about it, and maybe you can write this series up and share with more audience, wider audience. So you should definitely think about that, and a great presentation. Thank you for sharing that. So, Dr. Namalwar, I think, left, and Dr. Barako had to leave also. But thank you for our moderation, and thank you, Dr. Kalavani. I think this will conclude the session.
Thank you, Dr. Amrish. Thank you, Pankaj, sir. It was very nice hearing from the author of UTI. Thank you, sir. Thank you, Dr. Sunil.
Thank you, ma'am.
Bye-bye, Amrish.
Bye-bye.
Bye.